all, thank you very much for the very kind introduction, Dr. Marty Carter-Harsh. It's really been a huge pleasure to work with you and to put together many activities. He's a man full of ideas. You know him very well, so he has always incredible ideas, and we are very happy that we can work together and put some programs together like this program, which was his idea, and then we enthusiastically participated in making sure that this will be a success, and you have to be congratulated for your successful, the way you do things. It's always with success. You like Midas King, where you touch, you know, it really becomes a very stimulating and very relevant meeting. I'm also very happy to see here all of you, dear colleagues, at this time of the day. And I do understand that I'm the only reason between you and dinner, so I will try to make sure that we'll do this on time. So what I will try to do now for the next few minutes is actually to give you a little bit of a glimpse on what happened in London. London was a big meeting. Close to 34,000 health professionals actually attended the ESC Congress in London. Many of colleagues coming from India attending the Congress. We were very happy with the whole organization aspects, which it's always a little bit cumbersome in such a big meeting, but most importantly, we were very happy with the science that was presented, with the data, with the discussions, which at the end, to fulfill our mission, to improve patient management, to reduce the burden of disease. We had this year almost 12,000 abstracts that were submitted. So again, a very successful meeting. Of course, I'm biased being the president of this society. And here, just a reminder that you can actually follow a lot of the different presentations. You have the slides, you have even for many of the presentations, the presentation itself, and abstracts and comments. So there is a lot of different sources of education that you can actually get through this ESC Congress 365, which really has started a couple of years ago, actually with Keith, and we very also believe that this is very important to disseminate knowledge and to improve education. Just a word on the next Congress, which will be in Rome this year, and again, we really hope to have a very good turnout of colleagues coming from India. We always have a spotlight. This year will be the heart team, and there's going to be different sorts of activities. It's going to be again, and by the way, the deadline for abstract submission is the 14th of February, as always, Valentine's Day, and we certainly hope also to have a good contribution from India. These are just a reminder of some of the dates. The next one will be the 14th of February, which will be, again, the deadline for abstract submission. But let me give you a little bit of a glimpse. Of course, in such a big meeting, there are so many different presentations. We have, at the last day of the meeting, a session which is called the highlights, where we present by different experts, by different colleagues, and I have to thank these different colleagues. In the bottom, I have the name of the colleague that actually put together, and here I only have a summary of some of these presentations, but it's actually a very successful session, which is the highlight session, where the 9 different topics are some selection of what were considered as the highlights of the meeting. And of course, with so many presentations, with so many things, it's always difficult to have this sort of summary. So of course, this is just a selection. Many other things were presented. But let me just go through some of the highlights. Let's start with arrhythmias. In atrial fibrillation therapy, there was a very interesting study coming from Denmark, looking at the long-term results of ablation compared to antiarrhythmic drugs in atrial fibrillation. We know this is a big discussion, and this is actually the first study. It involves about 300 patients. It's the first study that shows that ablation on a long-term follow-up, and these patients were followed up for 5 years, and that, again, it was the first to show that ablation to be superior to only antiarrhythmic drug treatment for rhythm control over 5 years, with a 15% reduction in absolute risk reduction. And again, an important study with interesting results. Again, relatively small group of patients, but very well selected and very well followed up. The other one that was presented still in the arrhythmias was the so-called Xanthus registry. This is actually real-life data on the adverse events in patients with non-valvular atrial fibrillation treated with the rivaroxaban. As you know, there is always a big question between what is shown on the clinical trials with all the limitations that we know exist in clinical trials, inclusion criteria, exclusion criteria, and so on. It's a relatively selected population, so the question is how much the data that is shown in the clinical trials translate into reality, into the real-world life. And this is actually the example here of the Xanthus. This is the first large prospective study which describes, in this case, the use of one of the NOACs, or DOACs, if you will, rivaroxaban. And what it shows is that the rates of stroke and major bleeding with rivaroxaban were actually lower in routine clinical practice when compared with the results that were shown in the clinical trial, which, by the way, was chaired by Keith using rivaroxaban. Now, the next one is on leadless pacing. As you know, this is also one of the hot topics now in the arrhythmias world. And this is the new kid on the block, the leadless pacing, which is was almost a science fiction a few years ago, but now is the reality. And this is the 6-month safety and efficacy results with about 300 patients. And what is showed looking at the results, 96% implantation success rate with freedom from complications, very high. And the estimated battery longevity is 15 years, but again here we're still at the beginning, so there's still some data that we need to collect over the next few years. And there are, of course, some drawbacks, but the conclusion was that leadless pacing is a promising technology for patients who have indication for VVIR, and these results, they open up for future possibilities of more pacing modes and combinations, particularly when using, for instance, in patients like subcutaneous ICD. So again, new technology still needs some more time to make sure that the initial results will stick, but very interesting and very important new developments. Now, the other important study that was actually a registry that was shown was on lead extraction. We do know that this may represent a significant clinical problem. There is a European registry called the ELECTRA, the European Lead Extraction Control Registry, and the 12 months results, they were presented in London, and it showed that lead extraction is safe with a low 12 months mortality of 6.7%, and about 1 year, and this is quite interesting because 1/5 of the patients that had removed the lead, they were never reimplanted. And actually, it opens up some questions here, and particularly the chance to reconsider indication for device therapy. So certainly interesting data coming out of this registry, not only in terms of safety, but even to rethink some of the potential indications in these patients. Now let's move to heart failure, and in heart failure there were a few trials that were presented, and there was a little bit of expectation on some of the results of these trials. There was a trilogy of trials on left ventricular remodeling, and actually all these 3 different trials, for different reasons, they were basically neutral trials. We're talking about the PROMPT trial, which looked at the peri-infarct zone pacing to prevent adverse left ventricular remodeling, and these were in patients with large myocardial infarction, and I will just give a little bit of the data. The Albatross trial, which again in the heart failure patients looking at the aldosterone lethal effects blockade in acute myocardial infarction, and the Circus trial, which was the use of cyclosporine in patients, and I will come back to this trial in patients with acute myocardial infarction. So the PROMPT trial, it went over 3 years, 126 patients, and again here the concept was trying to pace around the peri-infarct area, particularly in patients with large myocardial infarctions, and there were 3 arms, no implant, LV and RV pacing, and LV pacing only, with the 18 months follow-up, and basically the trial was neutral, so there was no significant difference. So apparently, at least based on these results, there is no advantage in doing this peri-infarct pacing to improve left ventricular remodeling. The other one is, as the second trial, is the Albatross trial, which again, in patients with acute myocardial infarction, in the first 72 hours, the patients were randomized to aldosterone blockade or control. And again here, it showed in the follow-up, and was about 1 year follow-up, that there was no significant difference between the control, the standard therapy, and the MRA group of patients. And again, was one of the sub-study analysis, actually, one of the analyses, the sub-analysis that actually raised some interesting questions in the discussion, was that there was one specific subgroup of patients where the results were actually better, and these were the non-STEMI patients. And again, it's just looking at this subgroup, so with the limitations that it has, but certainly it raises some questions, and it did raise some questions during the presentation of the trial. Another interesting trial that was presented was the ARTS on the use of finerenone versus eplerenone, and this was a dose-finding trial, and these were in patients with worsening chronic heart failure and diabetes and/or chronic kidney disease. And again, the goal here was to compare the safety and the efficacy of these different dosages, once daily oral dosages of finerenone compared with eplerenone. And basically what it showed, it was that the proportion of patients who had NT-proBNP decreased more than 30% at day 90 of the trial compared with the baseline was actually similar between the two groups, in the finerenone groups and the eplerenone group in the full analysis set. So it showed some similar results in the comparison of these two drugs. And here you have the breakdown of the results and the curves on the different dosages, and you can see on the top in red dosage of 10 to 20 milligrams that showed the better results in terms of probability of survival. So this is still the beginning of the study on this drug, and there are certainly now ongoing trials trying to look at going into a phase 3 trial for this specific drug. Now, the other interesting presentation that was actually a little bit surprising, if you will, was looking, as we know, the sleep apnea in patients with heart failure has been discussed for many years, and we do know that about 50 to 75% of all patients with heart failure, they suffer from this sleep disordered breathing. And actually, what the authors of this trial tried to look at was trying to see if by dealing with this and addressing this sleep apnea disorder, there could actually be some positive impact in terms of patient outcome, heart failure patients. But actually the results were quite disappointing. If anything, there was a neutral, for the primary endpoint was neutral, and when looking at all-cause mortality was actually, there was a trend in the treatment group compared with the control group, which certainly raises some interesting questions on the role of treating sleep apnea, central sleep apnea in this patient population. Now let's move into hypertension. There were also quite a few interesting presentations. One of them, which can be included on the, if you will, on the epidemiology side of hypertension, was actually data coming from the EuroAspire 4. As you know, the EuroAspire is a registry, and what it showed, again, is very disappointing, because it shows that overall there were only about 35% of the patients with hypertension that had controlled blood pressure. So again, from EuroAspire 3 to EuroAspire 4, and you see here some different, in some countries there was a little bit better results from one to the other, but overall it went from 28 to 35%, so no, from a statistical standpoint, no significant difference. So again, it shows that we are not treating properly this patient, or at least controlling properly these patients. And this is, as we all know, is certainly one of the big clinical problems we have, is still the amount of hypertensive patients that, even being recognized and even being treated, they are not well controlled. And we do know there are many reasons for that, but this just shows that we're still very far away of dealing well with treating hypertensive patients. Now, a couple of interesting studies. in resistant hypertension. This was the pathway study. As you know, resistant hypertension is one of the clinical problems that we face. So these are patients who are considered to have uncontrolled blood pressure despite being on maximal tolerated dosage of at least 3 different blood pressure lowering medications. And we also know that there's been some discussion on what should be the optimal drug treatment of these patients. There have also been some other strategies to tackle these patients. So the authors here, the hypothesis was that further diuretic therapy with spironolactone, so anti-aldosterone agent, will be more effective at lowering blood pressure than the alternative blood pressure lowering treatments targeting different mechanisms. This was the hypothesis, and actually the patients were randomized. And they were compared with the spironolactone, and the patients were either on the doxazosine or bisoprolol or placebo, 12 weeks per treatment cycle. And then what it showed was that for all the different comparisons, there was superiority of the group that was on spironolactone on top of at least three blood pressure reduction agents. And you can see here quite interestingly that this demonstrated the advantage of using spironolactone in this patient population. And actually the authors concluded that this is the first randomized clinical trial which actually directly compared spironolactone, an old drug, with other active blood pressure lowering treatments in patients with resistant hypertension, and the result in favor of the use of spironolactone, looking at the results, was unequivocal, and therefore we can say that spironolactone is the most effective treatment for resistant hypertension, and these results should influence treatment guidelines globally. And therefore one important conclusion is that probably these patients should no more be defined as resistant hypertension unless their blood pressure remains uncontrolled on spironolactone. Another important study was the parameter study, here using the new agent, the combination of an ARB with an neprilysin inhibitor, the so famous LCZ696 in patients with systolic hypertension. I will not get into the details of the mechanism of action of this combination of these two agents, but basically what it showed was that from the primary and the key secondary outcomes, there was a significant difference in the treatment group compared with the control group at 12 weeks treatment, both if you look at the brachial and central aortic systolic blood pressure in favoring the treatment group compared with the control group. And again, this is the first randomized study which demonstrates the ability of this agent to reduce both central and peripheral blood pressure more effectively than just an ARB, and this in high-risk older patients with systolic hypertension and increased pulse pressure. And so the results suggest that the use of this combination agent provides beneficial effects both on central aortic hemodynamics and function that could provide a therapeutic advantage beyond those that we can observe by only doing RAS blockade by itself. Now let's look at the acute coronary syndromes and acute coronary care. There were different studies presented. This is the circus trial that I've shown to you. We know from previous animal studies by the same group, Michel Ovis from Lyon, that this could potentially have a positive effect in acute myocardial infarction for reperfusion injury to be prevented by cyclosporine. So the patients, these were acute myocardial infarction patients that were randomized for cyclosporine or placebo, and the results were very disappointing again, showing no significant difference between the treatment group and the control group. There was a lot of discussion around the reason why this happened. Of course, one of them is quite obvious, is that sometimes the translation of animal models into human models is not exactly a linear translation. Also, there was some questions about the formulation that was used, particularly the emulsion that was used for this cyclosporine. But again, I'm sure there's still going to be a lot of discussion around this subject, and there's been a lot of interesting developments. We'll see. Now, the other one was on the secondary prevention after an acute coronary syndrome. Here is the Pegasus study, which, as you know, the Pegasus look at the use of two different dosages of ticagrelor, the 90 milligrams twice a day or 60 milligrams twice a day. And he was actually looking at patients, stable patients, who had an history of myocardial infarction 1 to 3 years prior, and they had at least one additional atherothrombosis risk factor, and these patients were discontinued of their P2Y12 inhibitor at different timing, and basically what it showed here was that there was a reduction, a more significant reduction when this withdrawal was less than 30 days after the event. So, and here you can see that there was significant difference for both dosages in the patients who had withdrawal of the P2Y12 before 30 days, again showing that it seems that, and this is the big issue of prolonged dual antiplatelet treatment, may be beneficial in selected high-risk patients like the ones that represented a subgroup that had been withdrawn less than 30 days of P2Y12 inhibitor. Now, just a quick look into interventional cardiology results. Here is the OptiDual coming back, a big hot topic on dual antiplatelet treatment. These patients, they were patients who have been 1 year on dual antiplatelet treatment, and then they were randomized on the following 3 years, either to continue the dual antiplatelet treatment or aspirin alone. And there was an early termination of this trial, as is well known, and basically it showed that looking at the primary outcome, the composite of death, MI, stroke, or major bleeding, there was no significant difference between the two, and actually looking at major bleeding also there was no significant difference. The matrix program was also already shown here, comparing the transradial with the transfemoral axis, which was presented before, and here the question was on the use of biliverdin if it was, if prolonged at least for 4 hours, more than 4 hours infusion, or stop the infusion immediately after the intervention if there was any significant difference, and basically it showed that there was no significant, so there was really not relevant to continue to prolong the perfusion of biliverdin in these patients. It did not affect the outcome of this patient population. The Absorb STEMI Trophy 2 trial was presented at the beginning by Patrick Serrais, and basically it compared, it went to look at the healing score and to see at 6 months follow-up if there was any significant difference between these two types of these new drugs and these new scaffolds, and basically it showed that there was, if you look at the healing score curve, there was no significant difference for superiority, and it was basically the same in terms of non-inferiority between these two, so there is comparable and near complete arterial healing after the use of these two different bioresorbable stents for STEMI at 6 months follow-up. Then the other study, and I'm not sure if Bernie is here, he was, but anyhow, was the 5-year follow-up on the famous FAME trial, and basically it showed that the results, the delta between the curves, it seems they continue to be parallel, so the cumulative events during this 5-year follow-up continues to favor in this trial the FFR-guided PCI. And again here, it's a registry. It's a Canadian registry comparing the transradial with the transfemoral axis in the acute setting, and again here favoring the use of the radial axis, particularly in patients with acute coronary syndromes with less bleeding. Now, a quick look into imaging. There were quite a few interesting studies presented about imaging. One of them, in the setting of coronary artery disease, was the platform study. It went to look at the clinical outcomes of a new strategy of using non-invasive FFR and to use FFR-guided diagnostic strategies versus the usual care in patients with suspected CAD. So these were patients with stable coronary disease. They were divided in two groups of patients. All the patients, they had, on one hand, planned the non-invasive test to have a functional assessment of ischemic heart disease, and then these patients either had the standard test or they underwent this new combination of CT angio with non-invasive FFR. And then the other group, they had already planned invasive coronary angiography, and again, they were divided in two groups. Either they went straight to the coronary angiography, or they underwent this CT angio with non-invasive FFR. And what is interesting here is that on the left side, you can see that for the patients who had planned non-invasive test, if they underwent this functional test, there was no significant difference. But on the right side, you can actually see quite nicely that in the group of patients who underwent this assessment, it could actually reduce quite substantially the number of patients that had indication for invasive coronary angiography. So again, maybe, and again, this is still early data, but maybe this could help to select the patients who will really benefit of undergoing coronary angiography. And again, we're talking here about patients with stable coronary disease. Interesting studies on the use of magnetic resonance to look at some pathophysiological insights into myocardial infarction. Here looking at macrophage infiltration and edema with the new magnetic resonance technique. And this is another one looking at another index, the perfusible tissue index, which again uses MRI. And basically here is trying to have a concept where you can actually have some indicators and parameters that can help you to define the patients who will do better functional recovery in terms of left ventricular function. Some interesting technological advances. This is a new algorithm in the patients that undergo coronary CT angio. And here we do know that there are some limitations in some of these patients. For instance, if the patient already has stents or heavy calcification, it might be difficult to have a good definition of the coronary tree and the coronary arteries. So by using this new subtraction algorithm, you can actually improve, and you compare here with the conventional coronary angiography, and it can actually improve the way that from a diagnostic standpoint you can look at the coronary arteries. Now, another interesting development is this so-called smart fusion imaging. And again, with the fusion imaging, you put together two different techniques and try to take advantage of the positive aspects of one technique and the positive aspects of another technique. For instance, better spatial resolution with better temporal resolution. So here, it's a new machine, it's a new technology that puts together, and you can see here one example. This is coming from Japan, where you can actually see CT angio on the one side and the echo on the other side. This is an example of an ASD, and this potentially, and again, this is still the beginning, this is still a prototype, but you can actually take advantage of the better spatial resolution, for instance, of CT angio with better temporal resolution of echo, and may improve the way we can do diagnostic studies. 3D printing is everywhere, and it's one of the hot topics, not only in medicine, but many other areas. This is work coming from Italy, and they went to look at the tricuspid geometry. We do know that we have limitations on the assessment of the tricuspid valve, and here they went to look at the feasibility of 3D printing of the tricuspid valve from images obtained with 3D transthoracic echo. And you can see here in the bottom right is I have the same problem as Bernie had with this pointer, but anyhow, on the bottom right, you can actually have this 3D printing, which could be very interesting and useful to discuss, for instance, with our surgical colleagues, maybe do some better surgical planning and have the printing of the valve itself, which particularly in this setting of tricuspid valve may be quite difficult. Last, I will just spend a couple of minutes on valvular heart disease, a couple of interesting studies that were presented. One of them is the impact of myocardial fibrosis in patients with aortic stenosis. This is an MRI-based study. And again, here you may have an additional way to look at patients with aortic stenosis and try to understand, for instance, why some patients recover better function than others, and maybe identify windows of treating some and selecting some of these patients with aortic stenosis for early treatment, which we know is either today is either TAVI or surgical treatment. And what it showed here was that the patients who had fibrosis or had an infarct pattern with the late gadolinium enhancement, they had the worse outcome than the patients who had no changes in the late gadolinium enhancement studies, which means again that this may subselect patients that have worse outcomes, so maybe these patients will benefit from early intervention. One important study here in patients with acute infective endocarditis, the prognosis of acute infective endocarditis seems to be dependent, particularly in the patients who have an acute onset of the disease, on the early surgery, the early intervention in these patients, which is actually now translated into the guidelines on endocarditis that treating early these patients, in particular if the patient has surgical indication, the earlier the better in terms of outcome. And this is particularly important in the patients who have acute onset and endocarditis. A couple of important aspects in TAVI patients. The existence, this is an important study on the existence, either the pre-existing or the new onset of atrial fibrillation, and we discussed today the left atrial appendage occlusion in patients at the same time you do TAVI. Here actually it showed that the pre-existing atrial fibrillation in TAVI patients was a predictor of long-term mortality, and also in the other group of patients who had new onset atrial fibrillation, it predicted cerebrovascular events at short term after TAVI. So this certainly raises the question of doing preventive oral anticoagulation in this patient, in some of these patients, which may actually reduce or improve the outcome in some of these patients. This is a study which went to look at transcatheter mitral valve implantation. So now we're talking about the mitral valve. And these were high-risk patients with degenerated bioprosthesis or ring angioplasty. And basically what it shows here, these patients, they have not such a good outcome, in particular if not treated. In this case, you can see in the bottom left, there was a significant improvement in terms of functional results. So they went from New York Heart Association class 3 or 4 to most of them into class 2 or 1. And then on the right side, you can see a significant reduction of mitral regurgitation. They basically went from class 3 or 4, and at day 7, most of them, they were either on class 1 or 2, which means that there was a significant reduction in the amount of mitral regurgitation by doing this new technique, which again, early stages of very high-risk patients. This shows this other study coming from Belgium, the relevance and the importance from a prognostic standpoint of having significant functional mitral regurgitation in patients with heart failure with reduced ejection fraction. And it basically showed that the patients who had significant mitral regurgitation, these patients had a worse outcome. And there was a successful improvement when proper medication was implemented. And there was a 45% improvement of mitral regurgitation with therapy in these patients. So it's a very important prognostic indicator, and it's associated with poor prognosis, the presence of functional mitral regurgitation. Finally, a couple of results. One is on registries. This is a registry on the use of the mitral clip, looking at predictors of 1-year mortality, which you can see highlighted on the box, like anemia, previous aortic valve intervention, renal function, left ventricular function, and so on. But it shows that the 1-year follow-up, there was a survival rate of about 80%, again, on this registry of more than 800 patients. And a few innovations. This is the transapical off-pump mitral valve repair with neocord implantation. 75 patients. This was done in Italy, and you can see that it depends on the type of lesion. If it's isolated P2 lesion, the results, they look quite amazing. But again, this is still the beginning, but it shows how you can do some intervention in this patient population with some innovative technologies. And finally here, the cardioband, which is a percutaneous annuloplasty for mitral valve repair. These were the first 40 patients, and you can see on the bottom how it changed on the left side from baseline to post-procedure in terms of the dimension. And on the right side, you can see how it evolved, the degree of mitral regurgitation from baseline to 6 months follow-up with, again, some persistency in the significant reduction of mitral valve regurgitation. So, my friends, this was a glimpse of some of the results that were presented in London. This year we'll have Rome. Certainly a lot of other studies will be presented, and we're certainly looking forward to have a lot of colleagues coming from India so we can be all together looking at some new data and try to do what we are aimed to do, which is to improve the way we do patient management and also the way we can reduce the burden of disease in our countries and I would say worldwide. So thank you very much again for this opportunity.